All right, so today we are going to share some of our reports from our case conference process. One of the reasons we do this is because we have our patients who are following us, and also our providers and some of our employees. Although we do provide these on a weekly basis, some of them do have a little bit more meaning. So I'm going to go ahead and share my screen. All right, so what we see here is patient engagement is extremely important. And then one of the ways that we actually make sure that patients are engaged is communication through different channels. So if the patient is not utilizing EMR patient portal, we then are able to still send them an email through our population health management database. So, and then these are the different emails that we have been sending, and this is anywhere from, like, if there's a sign up to us as a new patient, like this quarter now, if this is only 1 month, we already have 41 of those. Patient portal utilization, which this shouldn't be the primary tool. Mm-hmm. And also any of the consults that they have, blood work. If they have diabetes, like we separate them with the high risk if their A1C is over 9. And if it's under 9, but they still need to see dietitian or the nutritionist, we are able to follow up with our patients. And also now we included the screening process with the breast cancer, cervical cancer, colorectal cancer. And now they are part of our regular workflow, case conference flow. The other thing we have from here is, which actually is really important. We're going to actually go into the specifics to this, just to put it in perspective. Sean is going to explain what I mean in a couple of minutes. Mm-hmm. So these, when we do the case conferences, there are actually 3 different channels that we may be getting these consults. These orders. So primary care being the main source. And in some cases, specialists may be ordering, and because we are a multi-specialty practice. And also the other thing, which part of the reason that we do the case conference is our care managers. Now, data is extremely important, and data is power. What we are able to see from here is we can actually understand how we are treating certain disease. And you are going to say, well, how can you actually tell from this? And I'm going to give you an example from patients with morbid obesity. They get 85% of their consults through our care managers rather than the primary care or the specialist. So because we do this after the visits, or in some cases we are preparing the patient visit, what I see here is if we have to initiate the order, then maybe that specific problem is not being addressed at the time of the visit. Same with the nutritionist visit. So 86.2% of the total orders for nutritionist is coming from care managers. So now just to kind of give you guys a comparison, when we look at the pulmonologists, only 11.6% is being given by our care managers. That means they're already getting what they need from their primary care at the time of this visit. Same thing with the endocrinology, that number is only 35%. And once we explain this, it's going to make a little bit more sense. But I do want you to remember, once we get out of the report and going into the actual perspective of what this is, this 85% and 86%, those are going to be important numbers. Mm-hmm. Well, the other thing, surprisingly, although we are not a nonprofit organization, we still have, through our ACO, we still have 51 patients who are homeless. So this is important with social determinant of health. If you don't understand what patients are going through, then we cannot really deliver what they really need. So it would be kind of like not so smart for us to follow up for someone's colonoscopy who doesn't have a home.
Correct.
right? So, and then they're also going to use the ED emergency department more frequently than others. So then we work with the insurance companies and we engage them to see if we can actually work together to help these people. Let's see if, I think this is what I'm going to share for today so that we can actually go back to what we mean by certain diseases not being treated at the time of the visit, but then from the central office with our care managers, we are able to initiate that. And we discussed this topic last night in our ACO meeting, but I thought it would be important because patients also need to understand what we are going through.
Yeah. So as you just loaded up the slides here, as Kemal mentioned, this was brought up last night in our monthly provider meeting, but I want to touch on it also here in our live session. So as you remember, he just showed the report on the screen that we had the two large groups that were being, orders were being initiated by our care managers, and that was the bariatric surgery. So 85–86% on those. And just to remind you what he just said is the fact that these nurses, the majority of the time, are then initiating these orders after the visit. We do at times send out these orders in advance of these visits, but most of the time, to make sure we're on the same page with providers, we like doing it afterwards. That way, the providers had a chance to meet with the patient. We can review if maybe some of their medications are already addressing the problem, if we're seeing progress in certain things. That way, an order may not necessarily be needed. But for here, the topic of obesity, as you see these slides here, we know that it is sometimes a sensitive topic for providers to address with their patients. But the fact that we review these cases in case conference and we see that obesity is actually a really prominent issue and really prevalent too. The factor numbers that we have here on our graph is over 1,200 cases being reviewed. And of those, the patients that we had broken down, just to remind you that the BMI of anywhere above 25 is considered overweight. And then the thresholds are broken down with obesity of class 1 being your BMI between 30 and 35. Class 2 is BMI between 35 and 39. And then class 3, formerly known as morbidly obese, is anyone who has a BMI of 40 and above. So of those 1,200 cases that we happen to review in case conference, mind you, we're not seeking these people out in advance. It's just they're being reviewed and they happen to have obesity issues, weight issues that we're addressing as well. Of those that had a BMI of 40 and above, it was actually almost half. So it was 46% of those cases were morbidly obese. Of those 568 patients, 116 of them actually had a BMI of 50 and above. So that's really, really concerning. And as you're saying, with these orders that the nurses are placing, it seems to be falling on them a little bit too often, as opposed to the provider taking that initiative and being the one who's ordering these consults, addressing the issue of obesity at the source during those PCP
So the issue
visits.
is two-way, right? So the patients are also, and when we say this, so I know there are people who are out there, they're like, oh, they're blaming providers, physicians, or they're blaming patients. Yes, we are blaming everyone. Everyone needs to take accountability. That's one. The issue, the social stigma of morbid obesity is so clear with the data that we are sharing with our findings. So just kind of like, I'm going to go back to the actual report so that it will make it a little bit easier for our audience to see. So this is the total number of 1,865 reviews, and this is the BMI level here. So if you look at over 35 patients with the BMI over 35, they would have most likely from 35 to 39, they would have, with the comorbidities, would have the morbid obesity. But look at the percentages here. So this is 20. So here's 20%, 22, 12. So it's almost 60+% has morbid obesity. And then this is not it's not a special group of patients that we are actually working on. So this is like
random
patients, random in a way that we still have the high risk but
That
it's
is
not
true.
limited to morbid obesity, mainly with diabetes, hypertension, cardiology, COPD, psych, all those issues we actually, those patients would end up. But one common thing that we see again and again and again is morbid obesity. Now, understanding why this is so different than the others is because patients are not bringing it up, and the physicians and providers, they are kind of shy. They're shying away from bringing this issue up. But we want to be advocate for those who are dealing with the morbid obesity, and try to change the maybe the kind of like the clinical culture in this.
Yeah.
So
I would agree. Try to get the conversations to be a little bit more comfortable. And also from the approach you're saying, some of these slides that are being presented, you'll see how many comorbidities are actually associated with obesity. So, addressing obesity is going to help, their hypertension, CKD, all these other various conditions that they may be facing. So to shy away from it, like we're saying, is not going to be a sustainable approach, especially if it's this type of disease is something that can, exponentially get worse if it's not treated initially or early on, and the right interventions are taken. So just want to put the spotlight back on that as a topic.
Absolutely. So one other report that I forgot to share, and this is why we want our patients to be more engaged. And like the reason I started with the emails is because the group that you see here, these are patients. Let's just scroll back for a second. 1 second. So there's, it's just a record ID, but I'm going to take this other thing off. 1 second, please.
Sure.
So then people don't have a heart attack.
As you load that up, I'm going to anticipate the importance here is the A1C. So actually in the slide deck that was previously shown, you'll see right now, that chart on the left is the A1C and those glucose levels of patients with the obesity, and the fact that we see that correlation, the direct correlation that, their levels are at concerning levels, more dangerous. So I'm sure once you load this report up here, you'll be able to elaborate on that.
So these are the patients from our findings. Their last A1C that they have is over 9. So many problems, many compliance issues that we have, where either the medication is not being taken or the dietitian is not being followed. So this is important. And these patients, let's see, I think there were 50 patients left here almost. They still don't have their follow-up blood work. So that's part of the reason that we have to actually work really closely with the with our patients. So this is why our nurses are extremely important in our system.
Yeah.
So we are trying to increase the engagement, increase the compliance, and hopefully we'll be able to do a better job in time.